we spent a number of years trying to build a model that we thought would improve the information that you can get from hormone testing using, so Dutch, it's an acronym, Dried Urine Test for comprehensive hormones. So it's really this three-dimensional picture, and that's really what drove us to develop this test, is if I get one dimension in serum and I get two dimensions in saliva, and I can give all three dimensions by looking at this unique model, then I think I'm doing a better job of characterizing the patient with respect to those hormones so we can treat them better.
Bioidentical hormones, a really useful strategy for many people. Challenge? How do you measure them? Hi, this is Dr. Mercola helping you take control of your health, and today I am joined by Mark Newman, who's the founder of Precision Analytical Labs in Oregon, and he also developed the Dutch test. You know, when I was seeing patients, they always had the practical challenge of how do you measure hormones, because there's so many different ways and there's so much controversy surrounded with respect to 24-hour urine testing, saliva testing, blood testing, or the newest kid on the block, which is the Dutch hormone testing, which we're going to talk about today. So Mark has a really innovative, he's been working in labs for a long time, and I believe has developed, defined as the best, the go-to test that you need to get if you're considering bioidentical hormone therapies, or if you just want to do an analysis to see exactly what your hormone status is, because it really is a confusing topic. So welcome, and thank you for joining us today, Mark.
Happy to be here.
Okay, so why don't you give us a little bit more history that's expanded on the brief one that I gave to you and help people understand how you came to develop the expertise to develop a test like this?
Sure, yeah, my history is one of vocationally of, I always tell people I'm an inch wide and a mile deep, so I've been in a really narrow focus really my whole career, and that of hormone testing. So I've built and directed 24-hour urine testing, and then some blood testing, and a whole lot of saliva testing, and over the years looked at really the pros and cons of the three main tests that we look at, and then we spent a number of years trying to build a model that we thought would improve the information that you can get from hormone testing using, so Dutch, it's an acronym, Dried Urine Test for comprehensive hormones. So what we're looking at doing is, instead of testing throughout the entire day, is collecting spot urine samples.
Which is really inconvenient.
Well, yes, for 24 hours it can be a bit of a hassle to have to, if you have to collect on a certain day and you have to go to work, it can be a bit of a hassle, which is where the advantage of the saliva test comes in, is it's a lot easier to do, but you're missing information. Any test you pick, and that was my frustration, is, a urine test gives you metabolites you simply can't get in a blood test or a saliva test, and they can really change the course of your treatment, change the interpretation of what's going on with a patient. But in that test, the collection's not the friendliest, but the biggest issue is that the hormones that change throughout the day, so mainly we're talking about cortisol, but also melatonin. Cortisol bounces up as soon as you get up, or we hope that it does. In those first 10 minutes of the day, we're having this cortisol awakening response, and the cortisol really goes up a lot higher, and then it comes down somewhat sharply, and then it begins to drift down, down, down throughout the day. That diurnal pattern, that up and down pattern, if that is dysfunctional, if you're low in the morning and high at night, you've got a serious problem. But a 24-hour urine doesn't show you. That's really the advantage of a saliva test. So the point of the Dutch test was to capture all of that information. So our individual samples, we're testing multiple times throughout the day to get that cortisol pattern. And then we're taking an aggregate, and it's a little bit sophisticated, but just in the short version, an aggregate of those samples and getting a correlation to a 24-hour collection for the hormones that don't have that circadian rhythm, where we just want to know, hey, how much do you make? Estrogen, progesterone, testosterone, those types of hormones. So what you get is this uniquely comprehensive look at the hormones and their metabolites and the cortisol picture as it changes throughout the day to give you all of that information. But then the natural byproduct is it's easy to do. So
Well, thank you for that expansion, and let me just go into some of the specific details of the mechanics of actually performing the test before we get into the magnificence of the and the brilliance of the analysis and the interpretation that you provide through the testing system. So I've done all three, so the 24-hour collections, the saliva, blood, and yours. Actually, it's four. And the challenge with those, for those who have not done saliva testing previously, is that it takes quite a while. I mean, it's not just, it's not a few seconds, it's a few minutes, it may be 10 minutes. I mean, you've got to continue to generate saliva and put it in this vial, and it's really tedious and challenging, I guess would be the kindest way to describe it. So it's not the simplest test to do. I mean, it is simple, but it's just not as simple as the Dutch test, because all you're doing is taking. I mean, this to me is the absolute easiest. I mean, certainly with respect to the information you get. I mean, you could do a blood test, which technically, it's easier than a blood test because it's convenient in your own home, and all you have to do is pee in a strip and let it dry. That's the only challenge of this, is you have to let those strips dry, which is not really a big challenge, but you tape it on a table or something and you're dry before you send it in. But it's a great test. So not only is it I think it wins hands down by any stretch of the imagination for convenience. Nothing beats it. And with respect to, as you alluded, the information you get from them is really spectacular and far exceeds the value that you get on almost all the other tests. Not that they're invalid. I think there's a place for all of them actually. But if you want a starting spot or a screen, this to me is a hands down winner, bar none. So why don't we go into some of the limitations of the other tests that you described? You discussed the mechanics, and I did, of how they actually occur. But let's describe what information they provide.
Right. So if you start with blood testing, I mean, that's the most common. And I think sometimes as you veer into, call it alternative medicine, call it what you will, there's an overreaction and more of a negative feeling for blood testing than there really needs to be. Because for reproductive hormones, they're good tests. Looking at your estrogen, looking at your testosterone and progesterone, that's a good way to test. What you're really missing are two things. And that is, one is the metabolites of those hormones. So
yeah, I mean, excuse me for interrupting, but and they're good tests is because there's not a diurnal variation. Is that the primary reason?
yeah, I mean, most of those hormones, I mean, they can fluctuate a little bit throughout the day, but generally speaking, I mean, there's really good, solid research that says your testosterone value as measured in the morning in serum is a number that has meaning. And the same with progesterone. If a woman's making a lot of progesterone, you're going to see it in her blood. And it may bounce around a little bit throughout the day, and that's an advantage of a urine test, is it's going to average out those peaks and valleys, but those are still good, solid tests in blood. Again, what you're getting with the urine test is you're just adding to that picture. So if I take estrogen, right, I can say, okay, this woman over here, and I'm thinking of a specific case, she's high for estrogen. Okay, and she's got symptoms. She's got estrogen dominant symptoms. And then as I look in the urine, I see, aha, your metabolites, I would expect them to also be high because you're making all of this urine, but they're not. If you look at the specific pattern, you can see that there is sluggish clearance of this estrogen, and in the particular case I'm thinking of, we were able to give her some supplements to speed up that specific enzyme that cleared that estrogen, and her estrogen levels, estradiol, that main estrogen that she was making, it comes down as the clearance speeds up like it's supposed to. But that's a bit of information we only knew because we were able to look at all these metabolites, the whole family of estrogens, and say, okay, we can get a more precise picture of what's going on. So you're getting added information on the reproductive hormones. Then you move into the adrenal hormones, and that's really the big area where serum falls short. Serum is a good way to test, but it's not a good way, it's not a great way to test cortisol. In cortisol, in serum, and that's your stress hormone, right? That's going to give me energy. If I've got too much of it, I might be looking at anxiety or depression or weight gain and issues like that. So we want it to be, where it's supposed to be. And if I look in serum, I get a total cortisol. And that's a place to start. But if I move into either saliva or the Dutch testing, now I'm getting free cortisol, and that's better. But not only that, I'm getting the pattern throughout the day, and that's another improvement. So we can get more information on that cortisol, those adrenal hormones, by looking at saliva or looking at urine. then we find that saliva is still missing one big piece of information, and that is the metabolites of the cortisol, which are not, is something that really is, I think, the importance of that is starting to get to be better known. And in the best case you can look at that is obesity. When you look at obese people, you get a lot of situations where you can get misinformation for the patient if you're not looking at all this information. Here's what happens. You get obese, you make more cortisol, right? So you're making lots of cortisol typically if you're obese, but salivary values and serum values don't go up. But the urine metabolites, that's where it all is. You increase the production of cortisol and you increase the clearance of cortisol, so you get this load of cortisol that's found in the urine, but only as a metabolite. So you're going to potentially really be misinformed on what's going on for these hormones if you're not looking at both the hormones and the metabolites, as well as that pattern throughout the day. So it's really this three-dimensional picture, and that's really what drove us to develop this test, is if I get one dimension in serum and I get two dimensions in saliva, and I can give all three dimensions by looking at this unique model, then I think I'm doing a better job of characterizing the patient with respect to those hormones so we can treat them better.
Yes, indeed, and understand what the underlying pathology is. And in many cases, the actual metabolites of the hormone are more significant than the actual hormone, like testosterone, I would think. And one of its primary metabolites is DHT, or dihydrotestosterone, which is believed to be one of the primary risk factors for cancer, not testosterone, or prostate or cancer. So you want high levels of natural testosterone, but you want to have that conversion pathway to DHT minimized so that you don't have excessive amounts of that metabolite.
Right, and very practically we see this play out a lot in females, especially as you make testosterone, that's good, but if you're making too much of it, that's not a good thing. And you can see that in blood, you can see that in saliva, you can see that in urine. But when you go that extra step that you mentioned and say, okay, but I'm going to get more of these symptoms of high testosterone, if say I've got polycystic ovarian syndrome, where that testosterone is shuttling towards DHT and making me even more androgenic, facial hair, thinning scalp hair, acne, you can evaluate that. Which way is that testosterone going? And then not only that, if it's not the problem, you're not treating a problem you don't have. And if that is part of your problem that's causing these symptoms, then there are very natural things that you can do to go and intercede there and try to shift that back in a way that's going to be healthier for you in terms of feeling better and getting rid of symptoms that you're not wanting, that are related to not just the hormones but also the metabolites.
Yeah, thanks. So let's maybe, to help people better understand this process, describe a few specific patient cases which would illustrate the advantages of this system, because it is quite profound. And I've looked, as I mentioned earlier, at all the different ways of doing it, and was really confused and pretty much rose my hands up and said I gave up. I said, this is beyond my ability to rationally give a solid and confident answer to this, until I encountered your test. So, and now I'm really believe strongly that this is really a near ideal way to make the assessment at this point in time with the technology that we have today. So maybe give us a few illustrations as to some good examples that would point out the benefits of this type of approach.
Sure. So one example would be when people have a concurrent thyroid problem, right? So we're looking at reproductive hormones and stress hormones. So if you want to simplify it, boy hormones, girl hormones, and stress hormones, right? We're looking at all of those. And if you're looking at cortisol, the cortisol and the thyroid really play into each other well. So having a good blood test for a comprehensive thyroid panel can be really helpful as well. But let's take a particular example that I'm thinking of. It was someone that I knew well, struggling with some depression, some anxiety, and we test their cortisol. So how do we do that? We can do it in saliva, or we can do it with the Dutch test. And what do we find? Her results are high, and we say, aha, we've got something here, right? The free cortisol is elevated. We know that there's more depression in people who have elevated free cortisol, so we draw this conclusion and we say you are, quote, making too much cortisol, right? But then we look downstream and we look at those metabolites, and what we notice is they're actually low. And we say, hold on, what's going on here is you have high free cortisol, but the reason for that is largely because you have sluggish clearance of this cortisol, right? You make it, but you're not getting rid of it, right? The liver's not processing it properly to get rid of that cortisol, so the free cortisol is high, but it's not because your adrenal glands are pumping out lots of cortisol. In fact, they're not pumping out that much cortisol at all, and what we find is that that specific pattern happens when your thyroid is low, or it can happen when your thyroid is low. That's well established in the literature. So if for a patient like that, as she deals with her thyroid issue, there's going to be a response on the cortisol side. And so what we can do incorrectly is we can go chase that high cortisol and give people phosphatidylserine and all of these things to lower the cortisol, and that's to lower your adrenal, output of cortisol, but that's not her issue. Right, her issue is more nuanced and complex, and so when we look at all three dimensions of the cortisol, we get a fuller understanding. Another example would be, let's just say I'm just trying to get a good handle on your DHEA, right? So I'm going to measure your DHEA-S, and it's low. Well, what if you also have an inflammatory condition, right? Inflammation is a huge issue that a lot of people deal with. DHEA gets made by the adrenal gland. It gets turned into DHEA-S, DHEA sulfate. So that's a sulfation process. Sulfation is inhibited by inflammation. So if I have low DHEA-S, I could conclude I have normal DHEA, but the inflammation is blocking that. Or I just don't make enough DHEA, right? How do you know? Well, in the urine test, you can look downstream from the DHEA in a different direction at these very abundant metabolites that well reflect the amount of DHEA that you're making, and now we get the fuller picture where we see, aha, you've got inflammation, it's blocking that sulfation, but you're actually making decent amounts of DHEA. And then we move on and see that, inflammation also promotes estrogen production from androgens because it upregulates aromatase, and we can see that picture. But then are you clearing that estrogen? We can take a step further and look at that. Inflammation also is going to play into the cortisol in how it's metabolized very specifically. And again, you need the metabolites of cortisol to look at that. So these whole pictures really start to emerge when you get this more nuanced, complex, more comprehensive look at all of the hormones, the androgens and their metabolites, the estrogens and their metabolites, as well as cortisol, for this sort of fuller picture to, again, just try to make better decisions and go in the right direction to try to help people with their situation.
Okay, good. So one of the most potent clinical interventions that I've encountered with respect to improving mitochondrial dysfunction is a strategy called intermittent fasting, where you essentially restrict your eating to a 6 to 8 hour window. And that window is variable depending on actually glucose responses, which I describe in some future articles that I'm writing. But the issue becomes, many people are concerned, especially for women or those with adrenal fatigue, that they should not be doing this. I don't believe that's the case for a variety of reasons we won't discuss here. But nevertheless, this issue of adrenal fatigue is quite common, and this is just one circumstance where it comes up. So the way to discern whether that is really truly an issue is through a test like this. And really probably the finest way to make that discernment, and actually not only make that initial assessment, but actually to monitor and follow the progress of whatever clinical intervention you're using. So maybe you can discuss the evaluation of adrenal fatigue or adrenal hormone status, because it is, and let me preface this, enormously confusing prior to the introduction of your test, because there's so many different ways to do it, and you almost have to take a course just to come away with a rudimentary understanding of what's going on. But I'm sure you'll be able to simplify it and help us understand that in a few minutes.
Yeah, you can simplify it, but I think it is important to concede that you are simplifying it, because cortisol specifically is such a complex beast, right? You've got signaling going on in your brain at multiple levels, and then you've got your adrenal output of cortisol. And so what, really this message that we've had for a long time is that people that have low cortisol take situations like, PTSD or chronic fatigue. We see the low cortisol, and then we've jumped and said, okay, well, the adrenal glands are not producing as they should. Let's call that adrenal fatigue. And really, I think what the literature is and the research is starting to show us is that for I'd say most situations, that what's really going on has more to do with the brain signaling and the stress response than the adrenal glands themselves. Are they really fatigued? Or is there some other issue going on? And that's important, really as a group of healthcare providers, or as a movement, that if you're treating the adrenal gland, or you're treating the entire HPA axis, what goes on in the brain as it signals the adrenal glands, I mean, that's really a different approach. So it's important that the semantics of that we continue to kind of move forward on that and figure out what's going on. But one of the things that we've found is that, if I take a person who has low free cortisol, what we've taught really historically is that is, quote, stage 3 adrenal fatigue, right? And that really, I think, is a misnomer. What we find is that, just at its most basic level, is that when you look at the metabolites of cortisol, right? Because you can't see that in saliva, you can't see that in blood, but it's the best marker for overall production of cortisol. When you have these people that are, by this definition, stage 3 adrenal fatigue, about half of them or more are making more than average amounts of cortisol, right? They may be processing it more quickly, as in obesity. You get these huge productions of cortisol, but when you only focus on the free cortisol, you can call someone stage 3 adrenal fatigue that's literally making more cortisol than 90, 95, 99% of the population in some situations. So it's a more complex situation than that. So when we want to define adrenal fatigue, we really have to start changing our language, I think, a little bit, and looking at the bigger picture of HPA axis dysfunction, because what mainstream medicine would say, this whole thing you can just wad up and throw in the trash, because there's not legitimacy to that. And I think what we find is that there is common dysfunction here, and it leads to a lot of issues. The question really is it really an adrenal issue, or is it more of this whole system? As we go and try to fix people, is what are we really trying to fix? But again, with the lab testing, we really want to define what's going on with them well. And in some cases, they're making lots of cortisol. It's a more complex issue than just, hey, you're not making cortisol. So it's a really complex thing. And you just said, can we simplify it? So
the other component to this is actually the timing, because as you mentioned earlier, a sample is taken 4 times throughout the day, and in the case of women, because you're evaluating their female hormones, and if they're menstruating, those follow a certain cycle, so there's a very precise time of that menstrual cycle that you would take the test. So it's a lot more difficult test to take if you're a woman, because a menstruating woman, because there's only a few days of the month that you could take it if you're looking at your female hormones, which is a wise strategy for most women.
Yeah, if you want to look at your female hormones, then the idea is to collect in a typical sample or between about 19 and day 22, right? Which isn't too bad. You just got to pick one of those days, collect your samples, and then you're good. But it's worth the wait or whatever effort it takes to do that, because then you get to see and ask the question, am I making sufficient progesterone? Do I have too much estrogen? Not enough estrogen? That's the window that we want to ask that question in. If your only question is, how's my cortisol production? Yeah, then you can test any day. You test those 4 times, and you can get a really detailed look at how those hormones are doing.
And speaking of hormones, I opened up our dialogue with the comment that it's a useful strategy if you're going to use bioidentical hormones, but in many cases, bioidentical hormones are inappropriate, and there may be simpler strategies that one could implement to normalize the abnormal patterns that are found on your type of testing system, and your test goes into that very elegantly. So that's one useful strategy. And then on the topic of bioidentical hormones, I think it's important for me to emphasize, I have in the past, but I haven't done it for a while, is that I believe if you're going to use them, first of all, they should be bioidentical, natural, and they should not be applied under the tongue, intradermally, or through the skin intradermally, but I think through, at least this is based on Jonathan Wright's experiences, transmucosally. So for anyone, that could be rectal application, or for a woman a vaginal application. That goes right, because that really it's almost equivalent to an intravenous injection. So you bypass the liver metabolites, which is a really profoundly useful strategy. So if you're going to use them, your bioidenticals or hormones, and in some cases it's absolutely indicated, and you would get a better idea of the need and requirement for that with your type of testing system. But why don't you maybe even just comment on what I just said, and then also start to explain the very sophisticated, elegant, and easy to understand graphical representation of the analysis that you provide on this test. It's not that you just get this list, this uh, written list. I mean, you get a written list, but you get a colored graphic representation of what those results mean, and it's relatively easy to understand. It takes a while to look at it and read it, but it's understandable to most people.
Yeah, you're sort of marching through a number of the challenges that you've experienced with hormones, that I've spent like a decade trying to overcome, and that is bioidentical hormones. Like, okay, if you need them and you take them, how then shall you monitor them, right? Like it's a tricky question, because if you look at, like, Dr. Wright's done a lot of really good work on, okay, how should we best give this? And if you then concede and say, okay, a mucosal membrane is a great way to take up the hormone because it's a lot clearer what's going on and you're getting better uptake than, say, some of these other issues, and you're bypassing the liver. Okay, so then we say, well, how do I monitor them? Well, in blood, I'm going to get an up and down pattern, but gosh, I don't really know when the up is and when the down is, right? So I can show you, for example, results from a study that was published where they looked at 2 women, vaginal hormones, right? The peak on one woman was at 8 hours. The second woman, taking the same thing, had a peak at 2 or 3 hours, and she was at baseline at 8 hours, right? So if you test at 8 hours, like, does she need more hormone, or did I just miss the peak? It's hard to know. So here's where you enter urine testing and say, okay, we're going to collect over time. That's an improvement. But then you still have this issue of, if I put testosterone in an area where my sample's coming from, and the amount of hormone in that supplement is literally like 1,000,000 times higher than what's in a biological sample, I could contaminate it. And that's where we spent months trying to come up with a creative solution to this, and we did. We said, look, I don't test testosterone in urine. In urine, it's in a different form. It's a conjugated, what we call a conjugate, right? So it's testosterone glucuronide or testosterone sulfate. And if it's there as just testosterone, it's not supposed to be there. That would be a contamination. So we just created a special method that would remove and separate these different types of hormones to give you an average over time, because urine is better for that, and a non-contaminated sample to give us a better option to monitor the hormones, because monitoring the hormones can be tricky business, and you really have to ask the question, which test is best, differently for each route of administration. So oral hormones are different, which most people don't like oral hormones except maybe with progesterone. But if you put it on the skin, you put it on the mucosal membrane, the lab testings or questions change a lot. On our website, we've got a little matrix that people can download. And just pick what you're doing, and it'll go through, hey, here's what serum testing has to say, because sometimes serum testing works perfectly fine. If I've got an estrogen patch, serum testing works great. But sometimes it doesn't work very well, and so there can be some challenges there. As it relates to the report, that again is a challenge of, look, if I've got all these metabolites, and some of them, there's some complex nuances here, and I just give you a list and some numbers, that's not very helpful, because we don't want to spend hours digging through what this all means. So we do 2 things. One, we present it in a graphical way so that you can see it in that flow of, here's my estradiol, that's the estrogen I took, and then here are the 3 different pathways it can go down, and we can look at which pathway is preferred. Am I methylating well? Do I need to start thinking about some genetic defects in my methylations, and which can get you off on some other topics. But the other thing we do is what I've realized is, patient or provider alike, that still isn't enough sometimes. So we've embedded right on the front page of our report some tutorials to just walk people through each section of the report to say, okay, I think I've got this, but this cortisol thing is blowing my mind. Okay, watch the video. We've got a whole series of tutorials that can help you figure out either as a provider how to make sense of it, or as a patient to figure out where's my dysfunction, so that I can target maybe a provider specifically that has experience in adrenal dysfunction, or female issues as it relates to estrogen or progesterone. So yeah, it's really important when you get into a complex test like this that the report sort of tells a story, so that we can all figure out what areas should we be focusing on in terms of taking corrective action.
Sure. And one of the mottos of our site and the content that we provide is to take control of your health. And this is a type of test where you can do that, because the report, the format of the report, the colored, and I don't think you mentioned it was colored, but it is colored, which makes it much easier to interpret. Colored graphics really help you follow this complex progression of the hormones. And I think, how long have you done this test? It's like at least 5 years to 10 years, somewhere in that range, right?
So I've been kind of building it for 10 plus years, and we've been
Yeah.
offering it commercially for about 4.
Okay, so it's a lot. It's okay, right? And I was in under. I definitely started using it before you offered
You
it
you were
commercially.
tested first before it was commercially available. That's right. The
Yeah. So,
pioneer.
well, no, and I'm not saying that to brag, just to comment on the progression of
Right.
your graphical of your report, which has really improved quite dramatically over the years. So, I mean, you've really refined it. It's easy to understand. That a relatively literate consumer patient could take this report, read it, and understand it, and that interpretation and understanding could be aided by the magnificent video tutorials that you provide on your site to help you go through the process. I mean, it's so you can start from zero, and you almost essentially get a free course in how to interpret your hormone test, which you don't have to pay extra for. It's all there. It's free. So, but it's really a great, powerful tool, and just by commendation for really developing this useful tool to help people understand what's going on with their hormones. Because prior to this, it was really confusing and complex.
Yeah, thanks. I think it's really evolved, and it continues to evolve. And we want to give people obviously the best information, but also to make it as palatable as possible for both patients and providers. So again, you can identify, which issues need to be looked at and pursued, and to know when there is something, at the level that you need to go to a healthcare provider, and really get some intervention to identify what the problem is, and then to start making some improvements.
Yeah. So, are there any conditions or clinical settings where the Dutch test might not be appropriate?
Yeah, I think anyone who's selling lab tests tries to be all things to all people, and there are some scenarios where every test falls short. So you talked about bioidentical hormones, right? If you want to take a hormone, test a hormone, and then change the treatment based on the testing in terms of dosing, there are a couple scenarios where a urine test doesn't work as well. So taking sublingual hormones, which you're not a big fan of, and I can understand the drawback to that. Some providers like that. The problem is when you swallow hormones, you get a lot of metabolites in the urine, and it really makes the interpretation difficult. Sublingual is even more difficult because you're only swallowing part of it, and I don't know which part, right? Some people swallow 20%, some people swallow 80%, and that's part of the drawback, is you don't want to be taking them orally, but you kind of are anyways, even if you're being careful, and it really makes for a difficult interpretation. I cannot look at a woman on sublingual testosterone and say your dose is right, your dose is wrong. I have no idea. With the estrogen, it's the same thing. I can look at your metabolism and see, some of these metabolites we think are more cancer friendly and some are more problematic, and we can look at those patterns. That's good. But I can't really help you with your dosing, because sublingual hormones is just not a good match for urine testing in terms of trying to adjust the dosing. Our test, because of the way it works, and I don't want to get into too many specifics, but if you've got a kidney issue, a test that's based on spot urine testing is probably not the best option. So you'd probably be better off going in a different situation. We don't have reference ranges for kids, so the model is actually beautiful for children because you can actually do it. I mean, I've tested my own kids, but we don't have appropriate ranges for children. So those are kind of some of the situations: kidney issues, and then there are just
And
some hormone situations.
For kidney issues, are you referring to renal insufficiency where your kidneys aren't functioning properly? Would be
Yes,
the okay. So
right.
what type of creatinine levels would you be referring to? Above
So
1.4, 5, 6, over 2 for
I
creatinine?
think if they're outside of really just what's normal for that,
Okay.
it's probably a different direction is probably best for you. And the reason for that isn't as it seems. It's not because of how necessarily the hormones get into the urine, but in a spot urine, there's a something we measure called creatinine, which helps to correct for hydration. And so the test is based off the assumption that your creatinine is normal, which you need, normal
Hmm.
kidney function for that. And so what you'd get is the results would essentially be just shifted by, whatever's off in that creatinine, and that is, it's an issue if you have a kidney problem. We haven't had but a handful of patients where we've said, you know what, you probably need to go in a different direction. Here's your money back. This is probably not going to work for you in terms of being as accurate as it needs to be because of that issue. So it's not usually an issue, but that is, if you know you have a serious kidney, dysfunction, it's probably not the best test.
Okay, great. And there's might be some confusion about from people who are some of who are watching this may understand that urine's a waste product. So how is the hormones that are secreted and metabolized and excreted through the kidneys going to have any relevance to what's happening in the blood or the tissues? So
Right.
maybe you can follow that line of reasoning and provide help people understand why it's still useful.
Yeah, so let's just take one hormone just as an example. So let's take estrogen. Okay, so we're calling it estradiol. That's our main estrogen, but let's just call it estrogen. So if I've got estrogen in my blood, how then does it get into the urine? So what happens is in the blood, I've got the total hormone. Most of it's bound to a binding protein, right? So it can't get into the cell. It's just being carried around. And then a fraction of that hormone, which we really think of as the most important fraction, is the fraction that's free and, quote, bioavailable to get in and do something, right? That's the same fraction that's available for phase 2 metabolism, conjugation, some of these big words that lead it to basically be in a form that you can excrete it in urine. So what ends up happening is that urine ends up being a pretty good reflection of your bioavailable hormones. So when we do studies, because we're constantly doing clinical validation studies, because I'm a cynic when it comes to lab work. I want to know that this is what we think it is. So what we've done, for example, is we've taken women, postmenopausal women, premenopausal women throughout their entire cycle. So we've got super low values, we've got normal values. If you catch them at ovulation, you get these really, really big values, and we get blood, we get saliva, and we get urine testing, and we do correlation studies, and we find that for those hormones like estrogen, that the correlation to what's going on in your blood is really quite good. So yes, it's a waste product, but it's a reflection of what's going on at a meaningful level in your tissue. And so, that's a good question to ask, and the validation data needs to be there, and it is, and that's pretty well established in the literature as well, that those numbers track pretty well with what's going on. And what we've found, and one of the major advantages that I find with this test as it compares to saliva testing, is specifically for those estrogens, is people really like the concept of saliva because it's free hormone, right? So the concept of free hormone says, you know what, this is probably better because it's, quote, bioavailable. But what we find is that because there's so little there, right? There's 1,000 times more estrogen in your urine than in your saliva, is that when you just very practically, because we did this in this study, right? We sent this to like 7 different saliva labs, and we said, okay, we got this group of low women. These are 65-year-old women not taking hormones. We know they're low, right? And then different phases of the cycle ending at ovulation where it's really big. And what we found is in blood, we got this nice stair step. The lows, the early part of the cycle where they're a little higher, the later part of the cycle where they're higher yet, and then at ovulation you get these 4 steps, right? In urine you get those same 4 steps. And when we looked in saliva, they all kind of get squished together. So even though it's free hormone, it's just so hard to measure that the accuracy, I think, is really better for reproductive hormones, really in blood or in urine testing. But that data needs to line up, and so we've done a lot of studies to show that the serum and the urine, they tell a really similar story for those reproductive hormones.
Great. So, is it possible for anyone to order this test by themselves, or does it require healthcare licensed clinician or practitioner to order it for them?
So we would prefer that people work with their healthcare provider. When they've got issues on hormone testing, that's really the preferred way to go. The hormone test that we sell can be ordered on our website, but in most states, we can do that. They can go right to the website and order the test there. So there's what we call the Dutch Complete, which that's that whole thing of estrogens, androgens, metabolites, melatonin, cortisol, and all of that. And then the only other version is called cycle mapping, and that's more like I'm dealing with a fertility issue, or my cycle is just so wacky as a premenopausal woman that I really want to map this thing out. And so it's a little more extensive, it's a little more expensive, but you get this really expansive data of everything we just talked about, plus this tracking of the female hormones throughout the cycle to see, where is this issue? Is it what's going on with the estrogen and progesterone? So the Dutch Complete and the cycle mapping are the two options that people can go and get.
Great. And what is the name of your website where people can go to look at this?
So it's a Dutch test. So it's dutchtest.com. So DUTCH, dutchtest.com. So people can go on there, and there's a lot of video content if you want to just kind of look through, like, how does this test compare to saliva? How does this test compare to blood? Where are its proper uses? Where are its limitations? We've kind of broken that down for people, as well as now I'm done with the test. How in the world do I interpret in light of this information and that information? There's a lot of content there that people can spend some time geeking out if you really like your biochemistry and you're trying to figure out what's going on with your hormones. That can be helpful in trying to figure out what the issue is in a particular case.
Yes, indeed. That's probably one of the most important components, and the best benefits of your approach is this comprehensive tools for interpretation of the results. So what is the cost of the complete Dutch testing that most people would order?
So the test on the website is at $3.99 for the Dutch Complete. There are, just for a point of comparison, if you look at the Medicare value of this, you just say, okay, we test this, Medicare says you should bill it at that. If you add those numbers up, it's about $800. Some lab tests, if they bill insurance, usually take about twice that number, sometimes 3 times that number. So we're working hard to keep this a sophisticated test using lots of different instrumentation, but we're trying to, as hard as we can, to keep it cost effective. And for the Mercola listeners, we can put a $50 discount on there if you just put in a coupon code of your last name, Mercola. We can knock that down another $50 to make it a little bit more cost effective for your listeners to try to get in there and get a test and see what's going on with your hormones.
Is there ever a third-party reimbursement for that from insurance carriers?
So you'd really have to order it through your doctor. Like, go to your doctor and say, hey doctor, I want to order this test, get a script from your doctor, and then the logistics of it would be a little bit different that way. However, when you do that, what we've found, and this is why we're taking this approach, is they tend to cover about 60, 65, sometimes as high as 90%, but on average probably 60 to 65%. So if you go other routes, you can pay $400 or $500 cash for a test like that, or they can bill insurance, $2,000, sometimes $3,000. But if you can get it ordered through a healthcare provider, then we can give you an insurance receipt, and you can try to get reimbursement. And again, if you're average, you get a pretty good chunk of change back, and then it becomes a real cost-effective option.
Yeah, it's a great test, really useful strategy. Are there any other points you'd like to emphasize or bring out or review? Because there's a lot of information here, so I may have skipped over some.
Yeah, no, I think it's it's one topic at a time, and you kind of really have to break it down. Again, if you're on bioidentical hormones, you got to ask yourself, what am I taking? How am I taking it? What's the best test? We want people using this test when it's most appropriate for them. If you're on birth control, right, you're going to get less information on progesterone because your birth control is going to kill your progesterone production, right? So there, like a situation like that, you're going to get predictable information for progesterone and estrogen. So there's a little bit less value, but there's still all this information on the androgens and the cortisol and all of this. But yeah, that's really where the website, where we've tried to break down a lot of topics so people can help make decisions, and do the testing when it's most beneficial for somebody. But in most situations, because we're looking at so many things, you tend to find some things that you can look at and chase down with the help of your healthcare provider, or just independently to try to figure out what sort of things are actionable.
Terrific. Well, thank you for sharing your insights. The Dutch test is the one I use personally for myself, friends, and family if I'm going to be looking at my hormone levels or their hormone levels, and it's clearly the one I recommend. And then you would get this test, the complete Dutch test, which is a $50 coupon off, I guess, if you type in Mercola, which is very generous of you. Appreciate that. I didn't realize that you were going to make that offer today, so it was not planned. And highly recommended. It's dutchtest.com, just like it sounds, DUTCH test.com, and I think you won't be disappointed.